do we still have that bone there? And we're fortunate that we get away with that many times. But if we can pre-plan and make sure that we build enough buccal-alveolar structure, we're going to protect ourselves towards a more successful long-term result. And just another example again of what happens post-operatively after abutment connection. Historically, we are taught and know we want to expect one bone loss to the first thread. I think this is going to be somewhat of a paradigm shift, as we'll see in the upcoming years, that by changing the implant design, we can probably limit this in certain patients. Finite analysis of restorative materials. This is the next level. If the periodontist is going to be in charge of provisionalization, we need to truly understand all the different things that are stacked upon each other and consider these things not just for the provisional stage of it, but help the restorative colleague understand the different selections they have available to them in regards to abutment design, screw retained versus cement retained, dimensions of materials that are going to be built into this reconstructive process. So that ultimately we end up with something that truly looks like a tooth and mimics the tooth, supports the tissues properly, so that the long-term success is there for us. The implant-supported provisional restoration, an article that I hope to have coming out in early 2008, is again a very strong interest of mine, going back to 1999 in working with the PROS department in San Antonio on really understanding the importance of a provisional restoration, and to coin Frank Higginbottom, the ability to create a guided soft tissue contouring process in the healing stages of dental implantology. We're going to look at two different protocols for this. The one of the immediate provisionalization at the time of placement, and that of a delayed or an early loading protocol where we'll take a surgical index, create the provisional restoration outside of the mouth, and deliver it at uncovering. As the implant-supported restoration transitions through periodontal tissues, it must support the established, that we have established with augmentation procedures, both hard and soft tissues, or maintain tissue volumes, that we've preserved through our atraumatic surgical procedures. These maintained tissue volumes must be supported precisely to provide for a predictable aesthetic outcome in cases like this, where we've not just rebuilt enough bone for implant placement, but we've recouped soft tissue contours, and we'll look at that case in just a bit. Now, as I said, I'm going to get started with these case presentations from the standpoint of focusing on the provisional restoration. I will point out which protocol we took as far as the loading. And for instance, in this case, this is going to be immediate non-occlusal load. So we will place an immediate provisionalization, but it's going to be protected by the occlusion we set up. So a post-extraction periapical x-ray that did have a periapical pathosis still somewhat healing in. Like I said, starting with a nice diagnostic wax up. This is pre my guidance area, so the guidance I had was developed by the restorative dentist, not by a three-dimensional image. A nice surgical guide to guide me in the provisional restoration that's very simply fabricated chair side. As I go through some of these first cases, I'm not going to be going through the step-by-step approach to create this. We'll get into that more detail towards the end, but this is nothing more than an acrylic provisional restoration that is delivered out of occlusion and left to heal. Now moving forward with a customized titanium abutment. Adjacent tooth is also prepared for full coverage restoration. And here we have the implant supported restoration and the adjacent full coverage crown. Meticulous debridement of cement is a key to success, not just in the final restoration stage, but that's probably my biggest complication in why I'm going back to more screw retained provisionals, is the retrieval of cement. When we're putting these under surgical flaps that need to heal, it can be a real bugger as far as compromising our outcome and having to see patients on emergency basis. So here we have our final result, and one that with good planning we're able to achieve an aesthetic result that mimics a natural tooth with full papilla and nice soft tissue contours. We're going to take a step back to my day in San Antonio and just show you the first case that I worked up for a provisional restoration. This was more of a staged approach, and you'll see why, because the surgery was more of an advanced protocol where we're going to be placing implants and grafting at the same time. And I'll just walk you through the steps of fabricating my surgical guide of a hard acrylic rigid nature, implant spacing, and this may be a little bit different today than it was at this point, meaning we may try to even consider more narrow diameter fixtures to optimize the papilla, but this is we went into this case knowing that we did not expect to have a papilla between these two implants. So this is just the box out to allow for the fabrication of the heat-cured acrylic stent. Taking this to surgery where we're using our guide not only to direct our implant osteotomies, but also making measurements from the proposed CEJ to where our initial inferior osteotomy is of the sinus procedure. Indexing. Indexing is it's a great thing to do. I do it all the time, even if the restorative doc has not requested it, because more times than not, we end up using it to fabricate our provisional restoration. So this is closure. Patient's in an interim partial denture while we allow this all to heal, integrate, and meanwhile we can go back to the laboratory and construct a very durable long-term provisional restoration. These are the index, setting our implant analogs in our model. Now we're selecting some temporary cylinder abutments, and I've made a little black mark where we're going to cut those off, and these are the screw-retained provisional abutments that we'll use heat-cured acrylic to fabricate our provisional restoration. So here we have a screw-retained provisional that's going to be, again, very durable and is going to stand the test of time in regards to how long we'd like to have this patient in a provisional restoration. And here we are at phase 2, uncovering and the delivery of this provisional restoration, and sometime later, the healing. As I mentioned, we're really not aiming for papilla fill in this region, but just an example of where I got started with all of this, of creating a provisional restoration that is going to be utilized at stage 2. Just as more of an aside here, this is an implant-supported provisional restoration here. This case is a more complex case of perio first, then implant, then ortho. I'd never want to leave this out because it's truly a wonderful part of our practice, is working with talented orthodontists to achieve tooth movement and using implants as skeletal anchorage devices. Looking at the specific bicuspid site here, we're using a solid abutment, and we're then using a coping of some sort. This happens to be the Straumann coping, where we are snapping that onto the implant, trimming it with any of your favorite burrs here. This happens to be a carbide. Putting it back in and looking at our occlusal clearance, and simply picking this up with a vacuform and acrylic. This can then be contoured on an implant analog to create good marginal adaptation, using a finishing burr to come in and polish and refine our margins, and delivers this into the mouth. Oftentimes with these copings, if this was a surgical exposure day, I wouldn't use cement. I would snap it on and explain to the patient that it could come off. That's okay for the first 7 to 10 days. If it comes off, come in and see me, I'll put it back on. I would like to try to avoid the cementation process. In developing our peri-implant sulcus, mature tissue, and we need nice healthy tissue in a patient that's going to get ready to go through long-term orthodontic care. And as you can see, when we progressed, that this became much more than a single tooth implant provisional for aesthetic purposes. It became provisional restoration in each quadrant. Implants used for skeletal anchorage. This one happened to be in an osteotome lift. This was in a lateral window lift. These two are used for distalization and uprighting of the second molars, and the case is proceeding along quite nicely. So another reason of where provisional restorations became a must. They need to be utilized in this case to achieve the proper anchorage and ultimate tooth position, not just for the implants, but for the natural dentition. And these are the lower provisionals about a year into orthodontic treatment. This, again, kind of brings me back to the initial days. You'll see from the implant design that this case goes back a while, but I show this merely because the lateral incisor is probably the best candidate to consider provisionalization because of our ability to control the occlusion. Using a surgical guide, here's our implant placement following extraction with the horizontal defect that's filled in with a graft material. And in this case, a gingiva abutment was used to immediately provisionalize with a slight facial contour to it so we can keep that tooth truly out of occlusion. And then sometime later, this is a PA of the provisional restoration in place. Oftentimes you will not see that you have marginal adaptation. It's not because you don't have it, it's because it's not radio-opaque enough material. Now I've gone to some materials that are truly radio-opaque, and you can see both the provisional margin adaptation and using a radio-opaque cement is important, of course, too, to verify that you've debrided all the cement. And again, here we are sometime later with good preservation of the interproximal bone tissue around this fixture. We'd all like to see cases like this where we're pretty confident that because of the thick periodontal biotype we're going to be in good shape, but I'll just walk you through another example that really emphasizes once we've created these contours, how can we translate that into a final impression. So here we're again going for extraction and immediate implant placement with non-occlusal provisionalization. This is the day of extraction, implant placement, and temporary insertion. Sometime later with good soft tissue healing and preserving those soft tissues. Very common to see this very ulcerated peri-implant tissue, and not uncommon for it to bleed and be slightly uncomfortable when we disconnect. And here the process of creating a customized impression coping. This is the provisional restoration. So I've taken this off of the mouth, I've put a healing abutment on the implant while I do this chair side. This is nothing more than setting an analog in quickset impression material like a blue mousse material, and then putting the provisional abutment and the provisional restoration and more blue mousse around that so we can pick up and register the peri-implant profile that we've developed. Then an impression coping goes onto the analog, and then something like Duralay or flowable composite is used that's eluted to the impression coping and delivered to the oral cavity. This is two examples. There's our customized impression coping. Here is the provisional restoration set on an analog so we can come back. You know, oftentimes these provisionals will break down. A little bit of their marginal integrity will have been lost, so we can simply reline it and polish it so that when we develop this, it's picking up the exact or the ideal contours of our provisional restoration. And this is the customized impression coping intraorally. We all know that we cannot inject material down into that deep sulcus in the anterior zone with any type of predictability. It's not going to put the tissue at the dimension that we left it after the provisional is removed. So really the only true way to record that is with a customized impression coping. So we use this to go on to a customized abutment, a non-precious metal abutment, and final restoration. This is very recently after cementation, and this is some time later with good maintenance of the interproximal tissues and bone levels around this implant. Again, some time later. So we've been able to achieve good maintenance of our hard and soft tissues to what we'd expect given the implant design in this case. Here's a delayed placement, and again, we'll show you why, an early non-occlusal loading. And when we look at this patient situation, we not only have to replace a failing tooth, it's a failed apicoectomy. You can see the old incision line from the apical surgery up here. We've also got to close her diastema because that's a strong desire of hers to not only replace a failing tooth but to improve the smile for this individual that has a relatively high smile line and a very large diastema. So atraumatic extraction, you can see here that we do have a substantial periapical granuloma that is removed in a buccal fenestration that we're going to repair after thorough debridement using a collagen barrier down in that apical region. And then socket preservation. In this case, freeze-dry bone is used, and another collar plug is used over the top of that. And I'll certainly show you